So this case, yes, it's one of a young lady, one teenager, but you will see that we had documents for her since her childhood. So when she came at the clinic, she was 70-year old and she's left-handed. The epilepsy onset, in fact, was at 8 years of age. The semiology, as it was summarized in the anamnesis, was that initially she can fall down or presented with a kind of laughter without loss of awareness for approximately 10 seconds. And with time, we will see we have some videos to compare, but it was similar, but now she was experiencing some tingling in the left hand and left foot, with sometimes but not consistently laughter, then right arm failing movement with left arm stiffening. So a relatively complex motor pattern. We will look at that. And when she's standing up, fall lasting 15 seconds. And the seizures occurred in clusters. This is the interictal EEG when we saw her the first time. And you can see that it's bilateral, slow wave, can be sharp, slow, depending on the placement, but it was always bilateral and also distributed over the midline and more laterally. So now we can see that in this excerpt that this bilateral sharp wave, that is more the aspect of almost a spike and wave, were also bilateral, predominantly on the left side for this excerpt, but it could also be right side. So now you see you have another aspect of this bilateral spike and wave activity, and this time is maximal on the right. But very difficult to see if it was more frontal than temporal, even if the maximum of amplitude seems to be suprasylvian rather than infrasylvian. So this, I will show you some videos was taken in the previous hospitalization or by the parents at home. That was a seizure years ago.
During the screening of American Sniper, positive pictures of service members who visited patients and their own soldiers.
You see the movement of the right arm, the right leg, and the kind of stiffening and raising of the left arm. We don't see well the face.
Arm straight out, honey, you okay? What's your name? Okay.
So you have seen a bilateral motor activity, but different from on the right and on the left side. The rhymes it to be more automatic gestures, stereotypy, difficult to know, on the arm and on the leg. And what we see on the left side of the body was more tonic in the arm. I don't see very well the face in this video, very old video. And this is even before in the childhood, when she was hospitalized in pediatrics. Oh, sorry.
Yeah, see? Did I say? Jeffrey, you look wonderful. Really, sir? It was 50 years ago. I know, it's funny. Since I moved out, I have really missed your sense of humor, Jeffrey. Oh, baby. Your wit, your charm, your wit, your
you can see that the motor pattern is very similar, even if this video has been taken at years of interval. So you have always the same tonic posture of the left arm, extended and a little bit raised, and this movement, reptation movement, that means some would say stereotypies on the right side. Okay, so now it's the ictal EG pattern that we recorded last time at the clinic. So you can see that we have an onset now. Mainly it's made in the first time on a first stage activity. I don't know if you see, maybe you don't see my arrow. I don't know if I can, yes, maybe I can try to do this. Okay, now maybe you can see more. And so you see that now you have a first, pre-ictal activity. I don't know if this pre-ictal or ictal we can discuss, but it's sharp wave anyway, relatively rhythmic, mainly on the right side, suprasylvian and the midline. And obviously you can see some activity propagating on the contralateral side. And after this initial period, you have a modification. If you compare the pre-ictal and the ictal, it's clear here you have certainly a fast activity which appear with less frequency here, but you can see very well on the midline and also in the anterior part of the frontal leads, and also a little bit in the central region. And so this is the second part of the seizure after 15 seconds, when you don't see much except some slowing in the same regions. So globulit appeared like a right side ictal onset on EEG and in also ictal evolution. The semiology was considered as I said, we said this morning, probably frontal posterior, with a predominance of tonic posture, mainly on the arm on the left side of the body, with ipsilateral stereotypies on the right side. I don't know if you want to ask question now, or if you want me to go further, because I think it's relatively similar to the case presented this morning, even if the cases are certainly not superimposable, but there are some similarities. So interrupt me in case, okay? So on the MRI, although we saw nothing evident except this non-specific unilateral periventricular white matter, hyperintensity. These are only some selected slides. I'm sorry, I have not the full MRI, but we cannot see anything. But we were, interested by the electroclinical correlation. So we'll see that we made some more imaging analysis. We had, what is interesting also, that we made a PET. And what's interesting is that we had also in this patient an hypometabolism in the temporal lobe, I would say as usual. And there was some discussion about the insular regions, here, if here it's the thalamus or the basal ganglia, maybe here the insular cortex, and it was said that there were more hypometabolism than here. So that was about the PET scan. Maybe we can also see that there can be some hypometabolism here, but I am very careful in my interpretation of PET. What was many more significant was the VBM, which was made at this time. And what was interesting is that because it was relatively coherent with our electrical clinical hypothesis, you see that you have an image here in the mid-cingulate region. I don't know if you can say that. You have also an image here, and here it's more confusing. But I would say that this sagittal view can be convincing, or at least we could say that there is some, arguments, additional arguments to implant this region. It's situated here. Maybe Jorge will remember if we had discussion on this image or not. But here, the contours of the cingulate and the pre-SMA regions seem normal. So we had some hesitations as usual. But anyway, we were guided by our electroclinical correlations, and we took account of these hypothetical lesions to implant the patients. One other very good argument was the ictal spect. As you see, the ictal spect, the injection time was 8 seconds, was not bad. So for a seizure duration evaluated at 16 seconds. And what is interesting is that you have a clear hyperperfusion on the right side in the midline. You see here also, obviously, it's a medial lateral a little bit. You see that it's projected to the mid part of the cingulate and maybe the SMA or part of the parietal lobe in the paracentral lobule. Anyway, even if, ictal spect is always a snapshot in the seizure, again, the convergence between this element in the phase one was really encouraging. Also, we had a MEG in this case. And what is interesting, you see that the MEG dipoles were mainly in clusters. That means that you have some relatively restricted areas involved. In pink, you have the somatosensory evoked potentials to mark the central region. And here you see that it's not strictly medial, it's more lateral on both sides. And you have this cluster of dipoles who are relatively more central than precentral. So that's also one point you can discuss, because we must know that the MEG has more difficulties to localize the midline generators than the lateral. Anyway, the spikes could be there. And when you remember of the bilateral spike and wave, this makes sense. Neuropsychology make that was nice grade. The verbal score were low. Non-verbal scores are low to average. There's also deficit in working memory. The verbal memory was lower than the visual memory. Okay, the naming was also low. So it's a general relatively low performance. What we knew that the hemisphere was the hemisphere dominant for language is affected by her seizures, maybe. Remember that she was left-handed. Okay, so we decided to implant this patient. There is not much discussion about the indication for ECG, because clearly we were oriented with this region. You know that this region is always a challenging one because it's difficult to evaluate which anterior to posterior we are. We were also interested by the ictal spect, in addition to the semiology and the possible VBM image. And that will illustrate exactly what was explained by Jorge this morning, saying that when we have a relatively strong hypothesis, we explore accordingly. That means we will not put there an electrode in the temporal lobe, even if we're on hypometabolism, or will not go very frontal, very prefrontal, because it's clear that the semiology orient us towards the premotor, motor, and maybe the parietal system. You remember that you have a lot of connections, medial lateral, but also longitudinal in all these regions. As usual in these cases, we implanted bilateral electrodes because all these patterns, when you record them in ECG, are often bilateral. Obviously, when we compare, I had said, you see that the fastest activity are in the epileptogenic zone, but sometimes, it can be as fast anterior as posterior, difficult visually to delineate the epileptogenic zone. And when you take one or two electrodes, two electrodes contralaterally, the propagation pattern helps you to understand what happened contralaterally. I can explain more about that. So that was our hypothesis, paracentral lobule so plus or minus cingulate, post-central gyrus, because you remember she was talking about tingling sensations more recently. It could also be a pure precentral pattern, or, very early, the last of the last was somatosensory second. We had an electrode here, but it was also a ventral electrodes in case of surgery. So intellectual findings were interesting in that now you see the different electrode one are like this. One means that we are medial, and you see that we add permanent and consistent spiking with a very fast spike, I would say, in the medial part of the electrode N, M, and X. That in N, M, and X is part of the mid-cingulate gyrus or sulcus, and also going to the pre-SMA and SMA. That was the intellectual activity, obviously with some pattern of propagations, especially in the primary motor cortex here. And so that is the posterior cingulate in Y. And you can also have in the same electrodes intellectual fast discharge, mainly during sleep. Here it's a ECG, but you see that we have cut off all the slow activities, only to keep the fast element of them, and it's clear that you have really fast burst of activity. I remind it's interictal in the N electrode, in the M, that means also pre-SMA, SMA, and Y, also that's posterior cingulate, and X, it's a cingulate sulcus. So the interictal spike, as you see, were mainly on the midline, clearly, from anterior to posterior, and we recorded some seizures. So now I will try to change my laser to trigger the video. So this is a seizure recorded during the ECG of one of the seizures. I don't remember how many we recorded, but more than one, certainly. So you recognize the pattern. She's pursing the lips. She can warm. So you have, it was the same semiology as the one we recorded during video EEG, even if this one is very clear, because you see that even the onset is ipsilateral with this stereotypy of predominantly on the leg and the arm. You see a modification of the face expression too, with some purse lipped and a little bit of gesticulation and extonic extension of the left arm, which remained during the whole seizure. So that's now the pattern of what we see. So it's clear that after maybe some sharp wave at the onset, you have here a fast activity, a fast and tonic activity in the pre-SMA and SMA. They showed you exactly the same with the propagation to even more medial leads. This is in a sulcus. And in the also this is the paracentral lobule, the motor area of the foot that you see it's involved. This is the posterior cingulate, and this is the anterior cingulate. But it's now it appears to be apparently faster in the pre-SMA, SMA, and the anterior cingulate. It's synchronized at the end with this pattern of big activity, big slow wave activity at the end in synchronization. This is the onset of the clinical activity. You see that you have the correlations. You see that the correlations is late, as usually. And now you have the extent parameter of the left arm at the end of the seizure. So now we can see that now the reconstruction of the electrodes according to the pattern, sorry. So now you can more appreciate where it was. So you have N1, which is just, at the junction between the cingulate and pre-SMA. M1 is not involved immediately, that you see that it is late because we are in the leg area, the H exactly, and the Y in the mid-cingulate posterior and the head mid-cingulate anterior. So grossly, this region is involved at the onset with a fast activity. So this is a zoom on this activity, the EEG onset there. So you can correlate now arousal and asymmetric tonic, repetitive right arm and leg complex movement, and the clonic movement at the end. This is the reconstruction of the anatomo-electroclinical correlations. So you can see how it's interesting to compare the different patterns and also to confirm that what we recorded there with the electrode in situ is similar to the usual seizure of this patient. And so you can see now we recorded a lot of seizures just to show you of the pattern, organized after repetition of seizures. Now you see much more on the preictal pattern and its differentiation from region to region. And you can also now compare the different seizures. If you see the number 12, number 21 is even more evident with a clear fast activity in these regions, but you see that the pattern is similar. At number 25, you see now much better the preictal spiking will not emerge more usually, and you see clearly now the fast pattern in these regions. And you can just see that all these seizure patterns, electrically and behaviorally speaking, are really the same. So you know that in SEEG, the confirmation of localizations always come after stimulations. And so we were successful in stimulation of Y prime, which is, you will see in the mid-cingulate, that we provoke the same seizures as the usual, as the habitual seizures. And in a just more anterior part of the cingulate, we could reproduce the early seizure symptoms, tingling and numbness. That was very, very helpful. So this is the stimulations made by Juan Bulacio.
5, 6, 7, 8, 9, 10, 11.
Up and immediately
Like a seizure?
you can recognize.
Okay, it's over. That's okay. That's okay. Tell me your name. What's your name? Morgan. Morgan.
So it's clear that obviously it's more brisk because it's stimulation at 50 hertz, but you can recognize all the elements of the usual pattern. This is the stimulations, 2 milliamps, 4 seconds. And you see that the seizure starts before the end of the stimulation because you can see even in M, you have small artifacts, obviously, from the 50 hertz, but it's clear that you get the pattern from the spontaneous seizures, not only here, but also in some related electrodes, and again, the same as in the spontaneous seizures. So that's illustrated by this picture. So this is a summary of all the stimulation. That means where we induce the seizure, that means we induce seizure only in one very specific area. And we could have or other motor effect of stimulation, as usually when we explored area 8, that means frontal eye field, and other parts of the lateral and medial cortex. So that's the second part of the electrical clinical stimulations. So it was clear that the epileptogenic zone was similar to what we call the primary irritative, that means the spikes, because the interictal spikes were in the same regions as the preictal spikes, and it was all medial in the cingulate and neighboring pre-SMA regions. And so Jorge, I don't know if he remembers this case, I'm sure he does. So he practiced this resection. I will let him commenting about. That means it was a resection strictly based on the SEG with part of the cingulate gyrus and sulcus and all the region of the pre-SMA. And as far as I know, it was, so we know about the neuropathology. It was a focal cortical dysplasia, type 2B, and the patient, after 3 years, but now it's much more than 3 years, was seizure-free with 1 AD at this time. So that's for this observation. So the reason why I presented it was not forcing, it was because I think there was some similarity with what you presented this morning. So we can maybe discuss now if you need it.
Thank you, we are here.
Okay.
¿Hay alguien con preguntas en el auditorio? Yes.
Patrick, I remember the case well. I do have a question about semiology. So she starts with sensory manifestations in the foot.
Yeah.
And we did a frontal reflection. Can you explain to me what's the sensory manifestation in the supplementary motor area or in the cingulate? Because it's not completely understood. Because it's not parietal, it's frontal. So if you can make some comments. Yeah.
Oh, yes.
So,
yes. Thank you.
Manifestations can be related to frontal lobe epilepsy.
Yeah, yes. So yes, because it's in fact it's not known, but it's very classical. There are so yes, if I go back to this, so yes, it was. I just reread what it was. Tingling in left hand and foot. That it was contralateral, and what we know is that it's a current observation in the cingulate seizures. It's not consistent, obviously, that we can have some somatosensory manifestation. The most frequent is not in the limbs, but it can be the one of the most frequent one is a kind of a sensation in the back, like a chills in the back, preceding or accompanying the motor manifestation. That's relatively frequent in this region. But the fact that it is lateralized and in left hand and foot can be cingulate, I mean, with these tight connections with the parietal lobe, but you cannot exclude that, because as I mentioned, what we explored in the paracentral lobule, we saw that we had a clear, even if it was later, a clear burst of rhythmic spike in the second part of the seizure in the paracentral lobule, that means in the motor part we explored. We had not electrode in the parietal part, but it's quite probable that we also had the propagations to this anterior parietal and post-central region, explaining that. So two explanations could be purely cingulate, I would say, or it could be due to the connection with some midline parietal activities.
Thank you. ¿Alguien más? It's always difficult to only implant one hemisphere, right? You always want to have something maybe just to exclude the other side, but I wonder if the two electrodes you implanted on the right hemisphere, are they necessary, or like everything was so straightforward to the left, I think?
Yes, so I can explain more. We don't implant bilaterally in all the epilepsies we will explore, obviously, because it's in many cases it's absolutely not needed. It's relatively the bilateral implantation is more necessary in the frontal and parietal cases. So this bilateral is not, in this case, was not to test the lateralization. We knew about the lateralization. And you can note that even bilateral, this implantation was asymmetrical. We are only two electrodes on the other side. So what is the reason for that? It's because when you see in this patient the pattern of fast activity, it was relatively easy to localize. But in other situations, you could have a situation when after the preceding sharp spikes, when the spikes stop, you get the fast activity. And this fast activity could be simultaneous in all the electrodes exploring the paracentral lobule. That means even if we have the clinical semiology, it would be difficult to differentiate between is this faster, is this less fast, etc., to localize with more precision the epileptogenic zone. So when you have two electrodes contralaterally, as you have always a bilateral propagation, but the propagation on the contralateral side has not the same frequency. And so imagine that it is more anterior. You will see that the more anterior contralateral electrode, which has the fastest frequency than the posterior one. In other terms, the propagation pattern will make you understand that it is more anterior or more posterior due to the differential frequency of propagation. I'm clear?
Yes. Super clear.
So that's one of the techniques for interpreting ECG in the frontal and parietal case.
So I think this is, to me, it's from electrophysiological, it's fascinating, right? So you're using the data from the contralateral hemisphere to infer the patterns of implantation on the ipsilateral side. Sure, because of the connectivity between interhemispheres probably faster through the callosum. So in that way, you can make some reflections about the contralateral side.
Yes.
But what's important here is that there is a surgical aspect on it. The electrodes, they need to be symmetrically placed. Yes. So on the same orientation, at the same level of the contralateral electrode. So if you see the electrode M and N, I think it's symmetrical to the contralateral. So this concept that Patrick is alluding to, it works well if the electrodes are perfectly aligned one side and the other. And then you can do, if you do one side in one orientation and the other side in a different orientation, in a different location, close but not perfectly symmetrical, you're not gonna be able to do that interpretation. Would you agree with that, Patrick?
Absolutely.
Symmetrical, yeah. I think this is
sometimes when you cannot and when it's clearly different, you can also use it, but it's better it is symmetrical.
Yes, symmetrical.
Merci beaucoup, Dr. Chauvel. J'ai bien entendu.
Yes, there's another question here from Sebastián Ortiz. Sebastián.
Thank you, Dr. Chauvel. My question is regarding the improvement of the neuroimaging, because the historical aspects of SEEG, we have seen that we have implanted around the same amount of electrodes, despite the improvement of what you have shown on the VBM, for example. The VBM showed almost exactly where the focal cortical dysplasia was. So my question is, do you think that the improvement of the neuroimaging can improve the number of electrodes we are implanting? Because, we are in a low middle income country. So it's not that easy or cheap to implant that amount of electrodes and say, okay, you put a contralateral one or two or whatever. So do you think that if we improve our neuroimaging, we can improve the number of electrodes and the understanding of the epilepsy network that we are trying to understand with the SEEG?
I hope so. Your question is very interesting. About this case, I think that, so I am just having a look. I think that in fact the image, the VBM image, was a little bit more posterior than the epileptogenic zone. But whatever, I'm not. I think that there is certainly some relation between this image and the cortical dysplasia. Okay, so but I am just looking. We did not implant many electrodes in this patient. Yes, maybe in fact. I don't think we implant too many. I will say why. Because in this patient, even if we had a good, I would say, approximation, evaluation of where it was, of localization before implanting, the goal of SEG was not to remove the lesion, was to remove the lesion and the epileptogenic zone, even if they were more or less overlapping. But the fact that we implanted, we used, maybe here you have, for 8 on the right side, why we had 8 instead of 5, what is a result of it on surgery is that it allowed Jorge to have a smaller resection as if we had less electrodes. That means sometimes, and we have many cases like that, we have a good evaluation of the localization, but the indication for SEG is to try to have the most restricted corticectomy as possible. Okay, so that's the interest of having more electrodes. I say that because, when I started with SEG, it's a long time ago now, maybe 50 years, we could not implant so many electrodes for many technical reasons. And with the development of SEG, I think I did not push for that. But what I observe is that in any centers, people are implanted more and more electrodes. Maybe they are not enough skillful in semiology, that's possible. But maybe not. Maybe it's better definitions and better precision for delineating the epileptogenic zone. That said, I agree with you that we should use the maximum of our technological advance to have a better, I would say, a more strongly argued implantation SEG. What I see is that, when we, in the 80s, at the end of the 80s, when we got MRI, many teams declared it the end of intracranial exploration. It's over. Now we'll see everything with MRI. And I can tell you that the one who was saying that was my mentor, Talerac. He told me, Chauvel, it's finished. Now I will understand everything with imaging. And you see, the evolution is exactly the opposite. That means the more you have a technical advance and the more you are using the intracranial recordings. So I am not in favor of that. I have more for the restriction of indications as far as possible. But I mean that the progress is not in using imaging versus SEG versus neuropsych. The method is much better and much precise than in the past when you can really match all these informations all together. I mean, when you have good definitions in semiology, EEG, MEG, ictal spect, PET, MRI, and image analysis, yes, I agree with you. You go to a very refined hypothesis. But I would say none of the techniques eliminates the other. Even if some of my distinguished colleagues can claim that semiology is absolutely useless, I wait for them when they are explaining a case outside of the temporal lobe. And, I don't think they are very much successful. So, no, everything is evolving, even semiology. We have progressed a lot since the last 10 years, for example. But about the number of electrodes, again, to conclude my long comment, I'm sorry. In fact, it clearly depends on your phase one, on your video EEG. The best, the most accurate, the most documented is your video EEG, the less electrode you will need.
That's okay. Okay.
Sebastian mentioned. Patrick, can you put the slide of the ictal onset of
Yes.
the SEG, just the electrophysiology?
This one, for example. This one or another one?
I cannot see. Yeah. This one. Perfect. So, Sebastian, the resection that we did, the VBM was very, very helpful because kind of guided the position of the Y electrode, right? But the resection that we did was much larger than the Y electrode. That's where we put the VBM, where we explore the VBM findings, is on the Y electrode, Y mesial. But there was no lesion on the N, no lesion on the M, and no lesion on the X. And if you compare here, actually from all N, M, X, and Y is the least evident where the VBM lesion is. So back to your question, if I had guided myself to the VBM only, this patient will probably continue to have seizures, and we had removed the lesion. So again, I think that the imaging and everything so far, it can provide us some guidance of how to implant the electrodes and some guidance of where the epileptogenic zone may be localized, but it will not give us the information about, again, the extent, the limits of this epileptogenic zone. This is something that we cannot clearly see on the MRI only by this anatomoelectrical correlation that we're showing. So I think that is my answer to your question.
Thank you, Dr. Patrick. I just want a question because you know that in Colombia and in many parts of South America, we want to perform surgery without ECG. When do you perform a surgery without ECG? Because I know that there could be some cases that where we can do, if we have a good MRI, we have EEG, we have SPEC, we have PET, but do you perform any case of frontal cortisectomy or whatever without using ECG when we can try to do that kind of surgery here?
Yeah, clear. Thank you for your question. Jorge will certainly have his own answer, but I have mine. Also because maybe the practice was a little bit different in my French career than American one, because of the experience with ECG was not the same. So we started operating without ECG some cases of frontal cases, because that's a topic today. I would say in the early 90s in France, and because we took advantage of our experience in anatomo-electroclinical correlations. I mean, even if we had not a very clear MRI, in some cases, but for certain reason we could not do ECG, we could be guided mainly by purely the video EEG and maybe an ictal-spect, yes, even in some, I would say, not clear MRI positive lesion. And so what also happened in that, in case when you have an MRI positive, but you know an image is an image, and just Jorge demonstrated that very well a few minutes ago, we could guide the resection not only on the lesion, but on, for example, more posterior, more anterior, more dorsal or ventral corticectomy, guided on our knowledge on semiology. So yes, all this accumulation of data, of knowledge or anatomo-electrical clinical correlation during ECG informed the teams, learned to the team what to do without electrode. I mean, is the repetition of these observations that make us, I would say, better in video EEG. And you are better in video EEG with some input from the imaging, you can operate without ECG. I would say that's the goal, but it's always, a balance between, the number of hypotheses and your technological means. It's clear that when at the end of phase one, you have a unique hypothesis, you don't need ECG. I don't know if I answer correctly your question. I don't know if Jorge can add about his experience of that.
No, I agree with you. It depends on the pathology. Also, in addition to pathology and the location. Okay, so if you have a congruent non-invasive data that points to a certain area, and this area is frontal polar or far away from eloquent areas, that you have the luxury to perform a resection that is perhaps a little bit larger than just the lesion itself, and you can guide the resection. That lesion on the MRI is highly suspected, not like the first case that we did, but highly suspected of a dysplasia type 2, and you have a PET that shows very clear hypometabolism in that area. In that area is located in the frontal polar areas that there is no much eloquency, there is no damage, no harm to go a little bit beyond the lesion. And then everything points to that lesion. Yeah, I think we can do a resection with perhaps guided by intraopic cog in that location. But if you have the same lesion in a highly eloquent area, for example, the area that we are discussing today, in this case that Patrick shows, mesial wall, deep, where you have the sensory cortex there, the motor cortex there, the SMA there, and if you go a little bit beyond, patient's going to have a leg deficit, leg weakness, sensory deficit, and it's difficult. The surgeon's sweating because you are in the midline, deep inside, in the sulcus. It's very hard. It's very hard just to do the resection guided imaging. So for those cases, SCG to me give us the confidence that the clear demarcation of the areas, not more, not less. And this is so important for eloquent cortex. But when you are in non-eloquent cortex, there are very few areas in the brain that are non-eloquent, really. Then you can extend, especially if the images show very clear this is a dysplasia type 2A, 2B, and it is very nice congruent. But I have to say, the more I practice EEG, the inverse way I'm taking, and the more I indicate, because the more I got burned or mislead by those questionable lesions, and we go that, oh, that's a lesion, let's resect it, and then patient continues to have seizure. We have recently a very clear case with a posterior cingulate. It looks like a cortical dysplasia, very, very clear. Patient with bilateral temporal manifestations. Beautiful case. This is a dysplasia in the posterior cingulate that is spreading towards bilateral temporal. Let's just remove the dysplasia. And we did an SEG, and the lesion was silent. This patient had, in fact, by temporal epilepsy. So the more we do SEG, the more question ourselves. But again, the short answer is, when you have non-eloquent, very clear semiology correlation, maybe a dysplasia type 2, perhaps we could make a point.